Okay, guys, let's talk about migraine. Migraine management in particular. This is something a bit confusing for many medical students and graduates. At least this was my own experience during studying for step 2. The thing is, for the management of migraine, you have to pay attention, at least with regards to the step 2 exams. I'm talking about the step 2 exams right here. This is not a comprehensive algorithm. Anyway, there are two things to pay attention to when you are solving the question. First is in which stage you are right now. Is it the abortive stage or the preventive stage? So what do I mean by that? The abortive stage, you are talking about the management of a patient who is in acute pain right now, who is having headaches. Okay. The preventive stage is when the patient is symptom free. Okay, you want to prevent future attacks from occurring. So this is the first thing to put in mind or to consider when you are solving the questions. The second is the patient population. To which population does the patient belong to? Okay, which population? I mean, is the patient especially pregnant, or if the patient have cardiovascular problems? Pregnant is going to be repeated also in the preventive stage. Cardiovascular problem mainly in the abortive stage. Okay, it is a consideration here. So with that in mind, let's start. Uh, the abortive stage. The abortive stage, as I said, in which the patient is having acute symptoms right now. Let's categorize the patient into three groups. Okay, the first group is patients who are not non-pregnant and do not have any cardiovascular problems. The second is patients who are pregnant. The third is patients who have cardiovascular problems. So I'm going to start with normal or patients who do not have any other condition in addition to their migraine. Those patients, you are going to start with, let's say, the regular algorithm. You are going to start the first line. Treatment is going to be NSAIDs, so naproxen and stuff like that. If the patient is refractory to the treatment, he is not responding, then you are going to give them triptans. Okay, so the thing with the migraine, or let's say I think it is the conventional or classic theory, is that patients are having their the blood vessels and the CNS are expanding. Okay, they are vasodilating. So when you are giving them triptans are serotonin agonists. It's gonna cause the blood vessels to vasoconstrict. Okay. As I said, this is the classical theory for migraine. Anyway, let's pay attention to the algorithm itself right now. This is with regards to patients who are only having migraines and they are not pregnant or with any cardiovascular problem. The second group is patients who are pregnant ladies. Okay, so in these patients you are going to start with not NSAIDs, NSAIDs. You are going to start with acetaminophen. Okay, the thing is NSAIDs are not used during pregnancy, especially in the first and third trimester, because of their teratogenic effects. Okay, so in the first trimester, they will cause problems with the development of the renal system, and in the third trimester, you have to pay attention that these drugs will cause closure, early closure of ductus arteriosus. Okay, so you are going to start with acetaminophen. If the patient is not responding, then you can add codeine. So why I'm talking about codeine in particular, you want to choose a low potency opioid. Alternatively, you can ask the patient to try taking caffeine or maybe an antiemetic such as promethazine. If all these measures fail to improve the symptoms, then you can consider taking NSAIDs. Okay, especially if the patient is in the second trimester. If nothing of these is working, you can take a high potency opioid, okay, such as oxycodone. This is for pregnant ladies. Acetaminophen, then add low potency codeine, a low potency opioid, then give them NSAIDs or high potency opioids, okay? So, in patients who have cardiovascular problems, as I said previously, this is not a comprehensive algorithm, but only let's say taking notes from different questions, whether they dealt with the problem or not. This is not the main issue here. So what I found that in patients who have cardiovascular problems, the thing that you want to pay attention to is that you do not want to give them triptans, okay? Whether NSAIDs are the first line treatment or not, this is dependent on the cardiovascular problem itself, okay? So, for example, we know that in acute heart failure, you don't want to give the patient NSAIDs because it's gonna only cause the exacerbation of his condition, okay? So the important thing in patients who have cardiovascular symptom is that you do not gonna give them triptans, okay? You are going to give them metoclopramide instead. It has an effect on the dopamine D2 receptors, but will not cause systemic vasoconstriction. So this is the abortive stage. The preventive stage, the patient is symptom-free, but you want to prevent future attacks from occurring. We are going to subcategorize the patients into, let's say, two groups. One is patient who is not pregnant, and the second is pregnant ladies. So the patient who is not pregnant, the first line or the drugs that you are going to recommend are anticonvulsants, okay, such as topiramate and valproate. These are very effective in preventing future attacks from occurring. Also, you can alternatively recommend taking beta blockers such as propranolol, okay? Calcium channel blockers such as verapamil are somewhat theoretically also capable of being used, but there were no data, at least until recently, to support their usage as preventive measures, okay? So this is for non-pregnant ladies, non-pregnant patients, sorry. In non-pregnant patients, you are going to use either an anticonvulsant or a beta blocker, okay? In pregnant ladies, the approach is different. Those patients are pregnancy is a contraindication to use anticonvulsants, okay, because of their effects on the neural tube development. So in these patients, you are going to consider beta blockers, especially these with safe profile. So what do I mean safe profile? These that do not cause intrauterine growth retardation, such as metoprolol and propranolol. I think it was maybe atenolol. I'm not sure, but there was a specific drug which is beta blocker that was known for its deteriorating effects during pregnancy. So this is the management approach in general that you are going to need to solve questions in the step 2 exams, okay, for abortive and preventive stages. Let's do a quick recap. For abortive, you are going to patient who is in acute pain, you are going to subcategorize them into three stages, three patient groups. The first is, let's say, only with migraine. These are the regular algorithm. Start with NSAIDs, then if refractory, you are going to give them triptan. Patients who are pregnant, you don't want to start with NSAIDs, you are going to instead give them acetaminophen, then add low potency opioids, then you can use NSAIDs, and if nothing is working, you can have the patient take high potency opioids. In patients who have cardiovascular problems, the main thing to pay attention to is that you will not give them triptans, okay? So instead, you are going to give them metoclopramide. In the preventive stage, you are going to subcategorize the patients into two groups: the pregnant and non-pregnant. The important thing is that in the pregnant patients, you are not going to give anticonvulsants. So in non-pregnant, you are going to give anticonvulsants, beta blockers, and maybe calcium channel blockers. But in the pregnant ladies, you will not give any anticonvulsants. You are only gonna deal with beta blockers, especially these with high safety profile. So in case this made perfect sense to you, you could understand and memorize the algorithm. You do not need to watch the rest of this video. But in case you want to understand a bit more, this might make things a bit easier to you. So the traditional theory was that migraine attacks occur due to initial vasoconstriction. Okay, there is an initial vasoconstriction, then followed by a reaction which is vasodilation. Okay, vasodilation is what causes the acute symptoms. So in the initial stage, to prevent the vasoconstriction, as I said, it is initially vasoconstriction, you are going to give drugs which supposedly vasodilate the blood vessels. I mean, supposedly the mechanism is that they vasodilate, okay? This might be the case of beta blockers and calcium channel blockers. It might not be the case maybe for anticonvulsants and antidepressants. But anyway, in the acute and the preventive stage, the initial vasoconstriction is prevented by giving vasodilators. Okay, in the abortive stage, while the patient is having symptoms because of vasodilation, we will give him vasoconstrictive measures. Okay, we are going to give him drugs which cause vasoconstriction of the blood vessels, such as ergotamine and triptans. So if this makes things a bit easier, by all means use this part or section to memorize and understand. But as I said, this is the traditional theory. New data suggests that trigeminal neuralgia may play a role in migraine, and the let's say perceived or conceived mechanism of action is only coincidental, that these also have effect on trigeminal neuralgia, but at the same time they have some effect on blood vessels. So the traditional theory emerged that it might be a case of vasodilation first, then vasoconstriction.